Welcome, everyone, to Leadership at the Point of Care, the blueprint for successful clinical supervision and teamwork. This is part 2 of our clinical delegation and supervision series, and this is Ruth Hanston. So I'd like to tell you a little bit about myself in case you have not been involved in our first sessions. And so just to let you know a little bit about my background, the first session in this series was about the basics of the 5 rights of delegation and supervision. And so in that discussion, I did talk about my background, but I'm just going to share it with you in case you are not aware of why I happen to be talking to you about delegation skills. I've worked with about 175 organizations nationally, and I've written books and articles about how to improve teamwork at the point of care, and particularly with registered nurse clinical delegation. I did my doctoral research on critical thinking and clinical judgment, and I've put together a care delivery model, which is a shared mental model for how we work together, called Relationship and Results-Oriented Healthcare, or ROC. So we want to talk a little bit about some of the other potential resources for you. You could see that the National Council of State Boards of Nursing is a wonderful website for you to go to, lots of information there. Also, your own state Nurse Practice Act is an essential resource for you, and certainly your job description within your organization and the job descriptions of those that you serve with, as well as the National Council of State Boards of Nursing and the ANA Joint Statement of Delegation and Supervision, which is in your Hanston Learning Center packet of materials. We hope also that you have printed out your Leadership at the Point of Care Part 2 course handouts, that they will be helpful for you as we're moving through this program. And we do want to also call your attention to several other resources, and I've got the photos of those books there on this slide. The Home Care and Nursing Delegation Skills with Hanston Washburn and Ginny Kenyon, who is a noted national home care nursing leader. And I've always added a chapter on clinical delegation to Joanne Zerwick's Nursing Today series, so there's a chapter there that's a quick read. And also, Linda LaCharity and her group have a prioritization, delegation, and an assignment book, which is used for preparing for NCLEX, and there's some great exercises in there, and I have the introductory chapter. I've written that. So there's some resources for you to look at. So on your handouts, you'll notice that your second page of the handouts have your learning objectives and a chance for some critical thinking and reflection. And, really all of this is about the patient. All of this is done to help our patients have better clinical results. And certainly for us as care providers, if we have better teamwork at the point of care, we're happier, and so are the rest of our team members, and our patients are certainly more satisfied. Other providers like physicians notice that the care is much more organized and things go a lot better for their patients. So if we know that those are the overall results and why we should care about the expertise that we have in clinical delegation and leadership at the bedside, this particular module will be analyzing the current level of delegation, supervision, and teamwork in the norms and the usual daily schedule and how you work together in your department. We'll also have an opportunity to talk about the 4 Ps that are necessary for expert teamwork, and we'll orient you to those. And then look at our next steps for improving the care delivery model or plan that you have for how you work together effectively each and every shift or day or case. That's the overview of what we're going to be talking about. And just a quick reminder that in our clinical delegation skills handbook, there's a lot more to this than these short modules that we'll be using to help orient you to clinical delegation skills, that it's important that we know ourselves, our own barriers to excellence, our own difficulties, and whether or not we're moving along the novice to expert continuum, how we actually decide what needs to be delegated and how well we know our delegates and how we resolve the conflict and solve problems and all of those kinds of things. So it's a very complex critical thinking skill that we're engaged in, and we wanted to remind you of that key to delegation. The next step is to have some reflection, which is a critical thinking practice. And you'll notice on page 2 that there are questions there that we would like you to think about. The first one is whether or not your department or your shift uses a shared mental model of how the teamwork proceeds. And this could be a map. If we were to ask everyone who comes to work in your facility on your particular unit or in your department, would they have the same idea of how you're going to progress together through the care that needs to be done and how you were going to communicate throughout that shift? And given that, ask people to describe their plan or blueprint for working together. How is it that you folks reconnect? How do you talk to each other about problems that might occur? How do you give each other feedback? So given that we know already from our first module that initial direction is necessary in delegation and supervision, and that feedback is a part of that, how is that done in your department? Is it effective? Do you think that people get the information they need to do their work? Do they get the feedback they need to be growing in their jobs? How do you then measure the effectiveness of your teamwork? How do you know whether or not the work is being done well? How are you observing and evaluating? And then those longer-term outcomes, patient satisfaction, clinical results for each and every patient. How do you measure that? And then one of the very important things that we find from our work nationally with a lot of organizations is there's some lack of clarity around who should be doing what and what people's roles are. This is a big deal because if you can't count on people to do their jobs and you're expecting them to do it, then we end up with missed care. And thinking about the issues or problems that could emerge as the impact of people not understanding their roles and responsibilities, a good point to consider. The impact of those gaps. Quick review then. On page 3, we've reviewed for you the 5 rights of delegation and supervision from the National Council of State Boards of Nursing. Under the right circumstances, we ask the right person to do that right task so that there's a match with their competencies and their job description and certifications and such with the task that should be done based on that patient's preferred outcome or the goals that you have developed with that patient and family, and that the assistive person is given the right direction and communication to do the work, to report back appropriately, and then that they have the right supervision and feedback. So that's a reminder of those 5 rights of delegation and supervision that help us all really focus in on making some decisions about who should do what given the work that we have to accomplish. So take a minute to think about how we measure the results of our work. And many of you are aware, I'm sure, of the core measures that you may be looking at in your quality programs, whether or not patients are being given their flu shots or their pneumonia shots, immunizations, and, surgical start times and whether or not the antibiotics are given at the right juncture. All of those kinds of measures, as well as our acute MI and surgical site infection measures, all of those are related to the way we work together in an interdisciplinary team. But let's think also about how we work at a bedside team with RNs and assistive personnel. We know now that we aren't being paid for patients that are readmitted or if there are hospital-acquired conditions, such as we discussed in our last module. The impact of missed care that ends up to be pressure ulcers or falls with injury because patients are not being ambulated to the restroom, for example, and then they get up and try to go and they fall on the floor. Those are the kinds of things that we are looking at when we're measuring results. We also think about whether or not you're happy with your job and the other folks that you work with are happy with their jobs. Are people excited about doing their work and they're engaged in that work? Because there are some clinical results that are connected to that. For example, on units where staff are very engaged and happy with the work that they're doing, there tend to be less surgical site infections. So think about your culture of your shift. Is there griping? Are people happy and excited about their jobs and feeling very vital about the impact they're making with their patients? Or is there that sense of, we aren't really happy about the work we're doing and we don't get along well together? Think also about the length of stay, for example, for your patients. If you've got a total hip or total knee patient, are they getting out of the hospital in a reasonable amount of time, and are they being sent to the right rehab center if they need to? Those kinds of patient-centered clinical results. What does your patient satisfaction look like? If you have HCAHPS scores or Press Ganey or other patient satisfaction measurement, that's one of the ways we know that there's good teamwork. Certainly with low patient satisfaction scores, we know that there may not be good teamwork. With high patient satisfaction scores, we know the teamwork has to be good because otherwise patients would notice that people didn't seem to know what they were doing and there was missed care or people weren't responding to their call lights. When there's, for example, overtime and absenteeism or people are not really involved in their unit councils, those are some other ways that we know whether or not the work that we're doing together is very effective and whether our teamwork is effective. So those are some of the ways we measure teamwork. So you can be thinking about what's going on in your own particular facility or your own unit right now. What does this research tell us then about what's necessary for a good team? And you could think back at some of those teams that you've worked with in the past that were those wonderful teams, whether it was maybe even a sports team that you were on or if it was in your nursing career. We know that there has to be some kind of team leadership, whether it emerges from within or the kind of team leadership is important. We know that a collective orientation is a part of excellence in teamwork, that people think about working as not just individuals but as a collective to work together to get the results that the group wants to achieve with their patients. That there's a sense of mutual performance monitoring. So people are able to give each other feedback and they notice if someone's missing or they're not doing their jobs or they're taking care of each other in that way also and backing up each other, that we can adapt. If we've got a whole bunch of admissions and discharge, that we are able to figure out how to work together to make that work. Then we also know in teamwork research that the group has to have a shared mental model of how they're working together. This is what a shift usually looks like. This is how we communicate. This is how we work together. And there's closed-loop communication in that if I ask you for a blood glucose result or a finger stick result, that you get back to me on that, and then we make a plan based on that, that there isn't information that's just floating out there that never gets resolved. And that develops mutual trust. We can trust each other to work effectively together. This is some of the small group research information, and this is from a particular Kalish article. She quoted it from Salas, Sims, and Burke. So I think this is an important overview for what does a good team look like and what are the component parts of that team. One of the things that I know from working with critical thinking skills and also working together with lots of different organizations, is that when we have a results orientation or that vision of the future in our heads, that we can actually work more effectively toward the results because it's just the way our brains work. So if we've got that vision of this is what our goal is and this is what we want to achieve, we can do that together more effectively. So it helps us see the big picture, it helps us prioritize, and then if we all share the goal for that patient and family, that then we can work together effectively to help them get to those results. So that results orientation is a huge part of improving critical thinking. This last information here about including the patient in his healing process, I think this is very important, and we see that when we think about variance and satisfaction, and this particular study was done in ambulatory care setting, but 84% of the variance of satisfaction with the treatment outcome that patients had was related to this eliciting the patient's most important reason for undergoing the treatment. So why are you here? What's most important to you? Very big deal for patients and families. What then is a shared mental model? Well, when we think about other areas and other disciplines that use shared mental models, we think about the military, we think about information systems, because we are working in complex adaptive systems, very complex work that we do. So we use these, what we call theories in use, or shared cognition. So a shared mental model, it allows us to have a joint intention. So we're moving toward that same goal together. A map, a blueprint, a scaffolding, a plan, that may be another word for a shared mental model. And a lot of the work that's being done on shared mental models, research-wise, has to do with what we've seen occur in what works in the military, and again, also working in computers, and working throughout many people being involved in solving a complex problem from all over the world at different times and different places. So shared mental models, do you have that blueprint or scaffolding or plan that helps you work together effectively? If we think about the root causes of a deficit in delegation, this is what I find. I find that that nurses and assistive personnel really don't understand their own accountability. Many nurses think that, okay, the nursing assistants just are supposed to do their jobs and I don't have to bother with them. They should just do their jobs. And a lot of assistive personnel have said to me, hey, I'm working under the nurse's license, so I don't have to worry about my own accountability. Well, that being said, then a lot of leaders don't think that care is missed, and I find more that the staff nurses tend to believe that care is probably being missed from time to time. The other thing that I think is a big problem in the way we work together at the point of care is that the whole idea of delegation and supervision includes very complex critical thinking leadership skills. And unless we provide both some education about the concepts but also help people apply the ideas on site in their own setting, they may not feel like they have a chance to really apply these skills, and they may not become expert. And then there's this failure to follow up. I often see, unit counsel saying, hey, I think we should do shift report at the bedside, and we're going to work on this, and then there's a lack of follow-up. Or perhaps a manager or a leader does not follow up with someone who has a performance problem, and that becomes an issue for nurses being able to trust assistive personnel, for example. So what that means is then we end up with this parallel practice where even though this RN and nursing assistant team has to work together, they're not. and they're not talking to each other, and in some cases they're really angry with each other too. And the RN is saying, I'll do my job, you do yours, but then is upset because the INOs aren't recorded or some of the work's not done. And the nursing assistant doesn't know what is expected or really feels that their workload is unmanageable, and then they're angry because they were in the patient room and there was a stooling patient with C. diff and no one helped them, and so they're going to say, hey, don't call me out of a room when I've got a stooling patient. You empty your own urinals. Don't be calling me. So those are the kinds of things that are really root causes of the delegation deficit. And so I think that if we really try to resolve those issues and make teamwork work effectively, people will be happier with the work that they're doing as well as patients get better care. So that brings us to the 4 Ps for teamwork. On page 4 of your handouts, I list those 4 Ps, and on page 5, we also have another extra worksheet for you that just helps you see what the 4 Ps might be for yourself, for your patient, your team, and your organization. What we know is true of dealing with, certainly with a lot of change from a personal standpoint, as well as just your own joy in your life and satisfaction with your life, is if you have a clear sense of purpose and if it fits with the organization you're working in, and you have a sense of success about the impact that you're helping patients and families achieve and the impact you're making on your community, and it fits with your own personal purpose and picture of success, and then you know how to work to get that picture of success and that plan, and you understand the part you play and the part that other people play, then people are a lot happier. They're a lot more satisfied with their lives. What we know is true then of teamwork in an organization is that the collective work that we do together has to be clear. So what that means then is each team member has to have clearly in mind the purpose, picture, plan, and part for themselves as they relate to each patient's goals. So where is this patient going? What does he look like now? What does he want to look like? What's our plan for this patient? They have to understand how that fits into their work shift and their point of care team. How do we work together to help that occur? What work do you want me to do? What work do you want to do yourself? How should we work together as a duo or as a 3-person team to make that happen? They have to understand the 4 Ps for their unit or department. Is this just a dump unit that's the overflow of every other patient in the world that might come through the door of our ER, or is this a really excellent specialty unit that is versatile and is able to deal with a whole lot of types of patients? That kind of difference in the way you see what it is you do as a collective group, as a unit or department, is a big deal. And then the organization. What is your organization's mission? What is its impact within this world at large in your community? These 4 Ps will, if they're clear, it will help people be engaged and effective in the work that they do. So you think about your department's 4 Ps. And you'll notice on the bottom of page 4, we've given you a chance to think through how that fits for you. So how do you find out, and how do other team members find out what the plan is for the patients and for the shift? How does the patient and family's plan get communicated, hopefully at change of shift? At a bedside report if you're in acute care, or if you're in home care, for example, that might be something that you do on a weekly basis. And is everybody clear on the part that everybody plays? So who's doing what? Who's working solo doing this and that, and do they need help? And what is their role? So that you can count on people. And is everybody clear about the map? So when are breaks? When are checkpoints? When are we going to talk to each other and debrief? How do you get your initial instruction to work through the day effectively? Those are the kinds of things that really create success or lack of success for the work that's being done. So a shared mental model. I want to give you an opportunity to really think about relationship and results-oriented healthcare, and that it is a shared mental model. I'm just bringing this up as an example of how we've incorporated the steps of the day or a shift into the work that's being done, and incorporates the 5 rights of delegation and supervision. So you may have any number of other kinds of shared mental models for the work that you're doing, but this is the one that I teach, so I'm going to give you this as just an example to look at. So ROC, Relationship and Results-Oriented Healthcare, is a method to really teach a shared mental model or a structure of care for all the disciplines, and it's always based on patient and family short and long-term results. And then each expert practice is a part of the day, and it's broken down into steps so that people can really learn how to be more caring, more connected, more present. So we'll look at that bundle of best practices. And what we believe is, as Roger Dow and Susan Cook have said, is that we have to become brilliant at the basics to become world-class. We have to make sure that these basic things are occurring at the bedside in order for patients to get the results they want. So here's an example. So this is relationship and results-oriented healthcare. And you can see at the bottom, if you go to the very bottom of this slide, that you see that everything is based on the fundamental relationship with the patient and family, and knowing what results the patient and family want to achieve. Then we use our critical thinking and problem solving to help navigate them through the system, and we work together as a transdisciplinary team, so among all disciplines. So if you look at our clock in the middle now, and you look on the 7 a.m. or p.m., the assignments that are made are all based on each patient's 4 Ps, their purpose, picture, plan, and part. So the assignments fit with their acuity and really their current picture. What are they looking like now, and what do they want to achieve? That being said, we will then, in the third part or third module of this delegation, talk about acute care assignments, because that sometimes is a core issue for success of the teamwork and successful delegation. Secondly, then, we're going to make sure that our handoffs or shift report, which we would recommend is at the point of care or bedside, is done in a way that really talks about the patient's 4 Ps, and that during that period of time, hopefully, that you can plan with the team and give initial direction using critical thinking, and always making sure that you're including checkpoints and timelines and parameters for reporting, so that the assistive personnel know what is expected of them. So you can really combine a lot of that in your first, half hour, 45 minutes of your shift. That also would include your introductory rounds and the rounding that you do, which is step 4. We want to make sure it's included there, because if people are doing shift report outside the patient's room or not really, engaging the patient in that discussion, then we have to be able to eyeball our patients. The 5th step is probably the most important, and that is the registered nurse being at eye level, talking about the plan of care and really getting input and asking the patient what's most important to them. Then that information about the patient's goals that's something that is recommunicated and updated with the rest of the team. So that's step 6. Now that would also include other disciplines, and hopefully there's interdisciplinary rounds going on each day with a discussion about what the plan is for that patient, and the patient and family are having a discussion about that. And certainly those checkpoints that we talked about are happening throughout the shift, before and after breaks, before and after meal times, and that there's a setup time when there's a debriefing, so that you can talk about what's worked, what didn't work, and that we're certainly giving each other feedback both ways. What could I do differently as a leader? What could you do differently? And that information is taken to the next group to make sure that they know how to plan their assignments and that there's that handoff beginning again. So this is just an example of what a shared mental model looks like. We believe that you can't really get to the quality and the team satisfaction and teamwork and safety and patient satisfaction and even looking at cost-effective care and resource management if we don't have all these pieces in place. So we believe this, and we've seen it over and over. And we're going to show you a little bit of the information about the results that we've seen. Now, the 5 rights of delegation and supervision are incorporated into the 10 steps of ROC. So review that we have the 5 rights of the right circumstances, the right task is the right person, right communication and direction, and right feedback and supervision. Well, when we make assignments, we're making sure that we have the right circumstances and we're choosing the right task for that person and giving that initial direction and setting up the checkpoints so that the communication and feedback is started early on in the shift, and then that we do debriefing when we evaluate the care, and that we also talk about what we could do differently as a team. So that helps us with our critical thinking, helps us improve our teamwork. So that is how we incorporated the 5 rights of delegation and supervision into the 10 steps of ROC. Our next slide shows that in case you think that the registered nurses are saying, hey, you know what, we always give enough direction, it's not a problem in our facility, it would be a good idea to talk to assistive personnel and ask them if you get enough information and direction to do your work. This is just an example from one of our facilities when we do our online surveys. And we find that, a third of these folks said, hey, I get direction from too many people, or some said, gee, I received too much direction, or I could use more information. Too many people are telling me what to do. Those are the kinds of results we get when we actually ask nursing assistive personnel whether or not they are getting enough direction. Now, omissions and missed care, we need to bring this up because we know this is occurring. B. Kalish has done a lot of work on this, and so I'm going to show you a couple of slides related to what we've seen. She has done a missed care survey instrument that has been used in many different facilities, and when they ask nurses what kind of basic care is being missed, you can see the percentages are really high. That sometimes, 82% of the time, nurses said, hey, there are times that we miss turning, or we miss some basic care or care planning or assessment. And the reasons, no one's surprised about this, is not enough people there, or we're not deploying and using them effectively. Maybe the materials are missing that are necessary, linens and whatever, but communication is a big piece of it, and we can affect that by looking at how we delegate and supervise and set up a shared mental model. So there's more data. This one is from 2011 and from the American Journal of Medical Quality. And Dr. Kalish has looked at another group of nursing personnel and assistive personnel and saying, hey, do you find that care is being missed? And they found that ambulation 3 times a day or as ordered was missed anywhere from 65 to 85%. Mouth care 50 to 85%. Interdisciplinary team conferences, turning patients, discharge planning, and focused reassessment. And when you think about all the impact of all of this, you could have patients with DVTs, with emboli. You can have patients deconditioned. You've got, mouth care being missed. We know that's certainly an issue with ventilator-acquired pneumonias. If we're not turning patients, not only do we have decubes, but we also have things like pneumonia. And if we're not doing good discharge planning and teaching, then we have people coming back into the hospital setting, and those patients, maybe if they're readmitted, maybe we aren't going to be paid for those because they should have been able to stay at home if they were supported and the discharge planning was done appropriately. So this is all concerning because the impact could be big. Gail Bitt Bittner and Nancy Bittner, and Gail Gravlin have done work on, okay, so if we miss care due to delegation and critical thinking problems, why is that? There were 7 categories of issues that occurred. And so tasks being delegated, people were unsure of what they could delegate. Secondarily, a lot of nurses thought that they should be able to expect assistant personnel to think like RNs. I've seen this over and over. A lot of places have nursing assistants giving shift report to each other, and when that happens, there's a lot of information that their nurse never hears and they don't know about. For example, one of the assistant personnel was talking at a shift report about a patient who had, signs of a stroke. I interpreted it as signs of a stroke or a bleed, some kind of a neurological problem, but she interpreted it as the patient needs a 2-person assist now. And there was parallel practice, nursing assistant to nursing assistant. Sometimes the relationships are bad. There have been things from the past that haven't been debriefed, and so people are mad at each other for years sometimes, and they don't trust each other, and then we have issues with people not helping when there is a need. There's a lot of role uncertainty. Who should be doing what? What can I expect of this person or that particular role? There are sometimes communication barriers that are related to the way the unit is set up. I can't see the person, but also related to whether or not we've set up a time to talk to each other before and after breaks and meals and when we're going to reconnect. There are sometimes system support issues, maybe difficulties with being able to contact folks that could be resolved by having locator badges or phones or any number of things like that could support people in doing their work together effectively, or it may be even the times of the shifts and when people come into the work setting at staggered times, and it makes for handoff issues. But then it ends up with omitted care. So those are some interesting issues if you want to get that article and look at these related issues to delegation and critical thinking. The things that I see when I think about missed delegation processes, one is that I see that assignments often do not reflect clear lines of accountability from the RN to the unlicensed person, that it's not clear who that nursing assistant is reporting to and or is reporting to 4 or 5 nurses, and that's pretty hard. It really won't work well. Secondarily, there's not that shared mental model or clear understanding of how we're going to work together and connect with each other. There sometimes is a disconnect with patient and family results, so people don't understand the impact of not doing the care well, that, yes, this patient will have a pressure ulcer if we don't turn them. Fourthly, I think that sometimes initial direction is not set up effectively so that there are checkpoints and parameters for reporting, but it's more of a rote method by which, nursing assistants just given a sheet of paper and you're just supposed to do it. And no one ever knows whether that occurs or not, whether those tasks are done appropriately. There are often missed checkpoints or huddles throughout the shift where people are talking to each other about what care has been done and how people are doing with completing their care. And there are often missed opportunities for 3 to 5 minutes of debriefing and talking to each other about what worked, what didn't work, and really celebrating the results that you have helped your patients and families achieve. Sometimes there's not useful feedback. There are some good teams that are, functioning pretty well where the RN says, thank you so much, it was a great day, thank you so much. And there's not a lot of detail to that. It's nice to be appreciated, but not enough detail to help the team grow in effectiveness and in the way they work together. So remember, again, we've got to connect the 5 rights of delegation and supervision with the steps of the work that you're doing every shift. So particular times that we make sure that communication, feedback, and supervision is happening. Appreciation. Here's another slide that shows the amount of appreciation that nursing assistants feel they are getting. And you can see that some of them are saying rarely, or never and ask for more feedback, and really a lower percentage that say they always feel that they're appreciated. When people have been through our full Level 1 specialist course, you can see that the start out of the skill level in these particular skills, and then the post-training improvement in those skills. So we want you to know that if people actually apply these principles to their workplace over a period of time, that they do improve their skill level. Another thing that we wanted to talk about is how we give each other feedback. And there's this reciprocal process of feedback where it's a two-way street. If I see that something hasn't been completed, I would want to ask for that teammate's input first rather than saying, well, why didn't you do that? So I'm going to ask them about, gee, I noticed that those vital signs weren't recorded on these 3 patients. And then recognizing their effort. I know you've had it, we've had several admits I wasn't sure if it was done or not, or if it just wasn't recorded. And then sharing your perceptions. Let's find out about, why it wasn't done or is done, and then talk about why it was important and why it was important that I would know that the vital signs weren't collected and brought to me within a timely manner so that we could make Plan B to make sure those get done, and then work together for planned results. So asking, recognizing efforts, sharing your perceptions, and then making sure that we agree on future action plan and follow-up. So I've used this mnemonic device of ask, recognize, effort, share, agree upon a plan. So are you a SAP? It's a way to look at it. It's an idea anyway. And then we wanted to share with you as well the celebration checkpoint tool to think about ways that you can ask each other questions that help you consider how well you're doing and how you can take 2 to 3 minutes to improve your teamwork. The best teams do this. Let's update each other on any clinical situations. How did we do on a scale of 1 to 10? And if we have the same assignment, patient, or case tomorrow, what would you suggest we do differently as a team? And please give me some advice. What would you ask an RN or a team leader to do differently if you had my job? And what do you appreciate about it? What can we celebrate about what happened today? Mr. Jones went home. Mrs. Peterson is, getting better. She's going to go to the skilled nursing facility. Mr. Smith's family seems happier with the care. What is it that we can celebrate about what went well and give each other feedback about what we did well as a team? This can take 2 to 3 minutes, and if it becomes a part of your norm, a part of your day, part of your shared mental model, it really helps the teamwork improve. You don't have to ask all of these questions. Most important question, let's say if you're in an OR and you're done with the case, that you'd say, hey, what could we do differently if we were going to do this again? Give me some advice about what you would suggest. Puts everybody in that role of a consultant and taking a step back and looking at the teamwork in a different way. And then what do we need to tell the next group or team about what we learned? So now we are on page 6, and we're going to be testing your workplace. And to see, as you can see, we go from 0 to 1, not at all. 2 is rarely. 3 is occasionally. 4 is yes most of the time. And 5 is yes all of the time. Think about your workplace and see where there are gaps or positive scores that show how well you're doing. Do you have, number 1, a shared mental model or map of your shift or cases so that we know how to work together effectively? And I hope we've clarified that for you so you can determine whether or not people have that. Now, you may or may not, they may not share it. People might have a different model in their mind about how their shift goes, but it's good to find out. Secondly, is there a way that RNs offer initial direction to the team members that they are supervising? Maybe your charge nurse is supervising only one nursing assistant that's on your unit. And if that's the case, is there a way that charge nurse offers initial direction? Does your team routinely conduct periodically scheduled times to reconnect definitely before and after breaks and meals, to share clinical information and progress and update each other? Fourthly, team members all know whether or not the care has been done appropriately and is completed according to plan. Do they? Do you know? Number 5, both positive and negative feedback is offered freely among the team members. Do you think that's happening now? And if not, what do we need to do to make sure that people are a little bit more comfortable with that? 6, we routinely debrief toward the end of each case or shift so that we can update each other, celebrate success, and discuss what we would do differently if we had this same assignment or group of patients tomorrow. So figure out your score, because that is going to bring you to, really looking at what things you might want to do differently. Now I want to show you just a few graphs of what happens when people are really good at having a shared mental model for delegation and supervision. And this is the improvement in actual skill level post-specialist coursework. So you can see this group. And then professional practice skills, up to 37% improvement in this group. And then if we look at our novices, I really wanted to make this point of the improvement in the people from 1 to 5 years of service in nursing, and show the improvement in confidence in being able to ask for feedback and evaluate the care. And it's just incredible to see the improvement when these skills are actually applied at the bedside. We talked about measuring teamwork and the employee engagement, and one of our clients has quadrupled their employee engagement over a period of time when they were working with this shared mental model of ROC. And remember that there is a connection or correlation with employee engagement and the improvements with things like surgical site infections and actual clinical differences and correlations. You can see improvement with physician satisfaction scores and their perception of nursing care overall. You can see the improvement in Press Ganey or patient satisfaction percentiles with one of our facilities, and decrease of falls and errors. This is a decrease in pressure ulcer rates. This is a decrease in falls on one unit. Having enough time with the patients, that's an important one, and you can see the improvement there that nurses felt that they had enough time to spend with patients. Florence Nightingale said, "I attribute my success to this. I never gave or took any excuse." And I think that's a good thing for us to remember when we think about our next steps. Think about then on page 7 of your handouts, what have you determined are the strengths that you see in your area of practice and also the gaps? What are the things you can build on? What things need to have improvement? And what expert practices are lacking? What steps would you want to take to help our workplace develop into a better shared mental model for working together? Which of the 4 Ps seem to be missing? So if you think back in our discussion about the 4 Ps, and then that takes you to your commitment. These are all critical thinking exercises to really look at what we've learned, what we've talked about, and how that can be applied to the actual workplace setting. Think that through, fill out your worksheet, and it will help you be ready to complete your test. So thank you for joining us for part 2 on our clinical delegation series. And we hope that if you have any questions or need specific help, that you will contact us so that we can then get in touch with you and answer some of those questions. Thank you for joining us today.